Now, with that background knowledge, how to approach the GI biopsies? As I told you, we have to go layer by layer. Let us start with surface epithelium. In the surface epithelium, as I told you, it is architecture and cytological atypia. Always remember these architectural changes and cytological changes in histopathology. Whereas in cytology, you see only cytological changes. That's why we are finding it difficult in cytology. Whereas in histopathology, it should be better because we see both architecture and cytology. In normal surface epithelium, is there any loss? Is there any ulceration, loss of mucin, hyperplasia, or other changes in the surface epithelium? Cytologically, before going into the epithelium, you see, is there any intraluminal organisms? Remember, I told you first start with the luminal space. Is there any intraluminal organisms? Is there any inflammation? Is there any regenerative changes, metaplastic changes, or dysplastic changes involving the surface epithelium? When there is a dysplastic change, you have to classify them into low and high grade. Let us start seeing the pictures. Here, this is the autopsy stomach, erosive gastritis. Okay, so it is extensively hemorrhagic. When you take sections from the stomach, you will see a lot of ulceration and hemorrhage. So this is a active process. Okay, extensive ulceration and hemorrhage. As for corrosive poisoning, any other chemicals or any chemotherapy, clinical history is very, very important to make a exact diagnosis. This is the surface epithelial changes where the surface looks more villiform. This is a gastric, if it is small intestine, then it is fine. But this is a gastric mucosa, you see a lot of villiform changes. These villiform changes are very important in the diagnosis of chemical gastritis if the biopsy is taken from the antrum or pylorus. What happens there? The bile is trying to come into the stomach, so the stomach is trying to become small intestine. That's why you see villiform changes in the chemical gastritis. Here, what do you see in the surface epithelium? See, a lot of neutrophils are sitting. Remember, I told you this is equivalent to cryptitis in the colon. In the stomach, we call pit. So I don't want to call it pititis. It doesn't sounds very great. But you can see the neutrophils sitting on the epithelium. So this is a active inflammation. Here, now we are coming to cytology. You see in the intraluminal area or in the lumen, you see a lot of comma-shaped or rods sitting on the epithelium, not going into the epithelium. So these are all the H. pylori in the oil immersion. Here the surface epithelium shows goblet cells, and these are all biopsies from the stomach. So when you see goblet cells in the stomach, it is intestinal metaplasia. Another thing you have to remember, the stomach is having a acid milieu, acid environment, but the mucin in the stomach is neutral, whereas the intestinal mucin is acidic. That's why in PAS Alcian blue, the acidic mucin is taking the Alcian blue color, whereas the gastric mucin is taking the neutral mucin pink color. PAS Alcian blue stains the acidic intestinal mucin into blue. That is very essential to remember. Here what is happening? This is a colonic biopsy. You see the normal epithelium, single strand, single epithelium, lot of mucin, looks normal now, normal. When you travel all along, what's happening here? You see the difference between this and this. Here single layer of cells, mucin is present, whereas here stratification has started, loss of mucin. So stratification, loss of mucin. And when you go to high power, you can see lot of apoptosis and lot of mitosis. So this is a diagnostic criteria for dysplasia: stratification, loss of mucin. See how the amount of goblet cells, mucin. You see the amount of goblet cells. It is loss of mucin or less of mucin. Okay, again another normal epithelium. So this is the area, pyramidal area, that is pathologic in this biopsy. and there is mitosis and apoptosis. Remember these 4 criteria for dysplasia. See again here stratification has started, but you see mucin is less. It is, I won't say lost, it is less. And these stratified nuclei reach the middle third. They are not touching the upper top of the apical membrane. They are reaching the middle third predominantly. Okay, that is one important point. And other one is, look at this nuclei. They are all traveling in one direction. So the polarity is maintained. Okay, so those 2 points are very important. And the third one is no prominent nucleoli. Nucleoli are not prominent. And the fourth point is no cribriforming or micropapillary formation. So the predominant features you see here is the maintained polarity, nuclei reaching the middle third of the cells, no prominent nucleoli cribriforming or micropapillae. This is the criteria for low-grade dysplasia. Compare it with here. Here the cells are coming and touching the top. Can you all see the nuclei touching the top of the apical membrane? And see the prominent nucleoli. And see the nuclei are running in different directions. This nuclei is running in this direction, whereas this nuclei is running in this direction. This nuclei is running in this direction. So there is loss of polarity. Okay. So here also it is stratified, reaching up to the top, and it is showing loss of polarity. And see the cribriforming. And this is a micropapillary process. Since it's a high power, you are not able to appreciate it better. I will show it to you in the other pictures. But here you can see cribriforming. What happens in cribriforming? It is not crowded back-to-back glands. It is epithelial growth within a gland. This itself is a single gland. Within that gland, this epithelium is growing and connecting the other side of the lumen. So the intraglandular proliferation of the epithelium is very, very important criteria, which we call it as cribriforming for high-grade dysplasia. So this is a picture of high-grade dysplasia, and the criteria are loss of polarity, nuclei reaching the surface. Here you can see nuclei reaching the surface. Prominent nucleoli, if you see carefully for 10 seconds, you can start seeing the nucleoli, and cribriforming and micropapillae. This concept of dysplasia, low-grade dysplasia and high-grade dysplasia is very, very essential, because you can apply this criteria in any organ. You can apply it in the pancreas, you can apply it in the gallbladder, you can apply it in the bile duct, even you can apply it in the breast, you can apply it in the prostate, you can apply it wherever you want. These are all in the GI tract known as adenomatous changes with low-grade or high-grade dysplasia. In the other organs, it is known as dysplastic changes with low-grade and high-grade dysplasia. This is a beautiful picture. I got it from the Google, where it looks normal here. Low-grade dysplastic changes here and high-grade dysplastic changes here. See the cribriforming. Why they are not back-to-back glands? When it is back-to-back glands, you can see some stroma running in between. However, it may be crowded. See here, one gland, another gland. You can see the nice stroma in between. These are back-to-back glands. But see here, this is one gland, this is one gland, this is one gland, but no stroma in between. So these are cribriforming, which is intraglandular. Epithelial proliferation is happening within the gland, which is a feature of high-grade dysplasia. So normal epithelium, low-grade dysplasia, high-grade dysplasia in one picture. Thanks to Google. I don't know the source, but I thank the person, anonymous person. So those are all the changes in the surface epithelium. Now we are going to glands. Architectural changes. Variation in size, shape, distribution indicates chronicity. Cryptitis and cryptapsis indicates active inflammation. One thing you have to remember, active inflammation may be sitting in the chronic inflammation. So we will call it chronic inflammation with activity. Cytological changes, again look for organisms, atrophy, metaplasia or dysplasia, either low grade or high grade. So this is a squamous epithelium. This is a gastric cardiac type of epithelium. So this is a gastroesophageal junction. Here you can see nice bifiding. And see the glands are not uniformly distributed. Variation in size. Some glands are small, some glands are large, and these glands are not branching normally, but you can see a nice bifiding. So these are all features of chronicity. Irregular size, shape, distribution means chronicity. Please remember, presence of lymphocytes and plasma cells is not feature of chronicity, but architectural change by the way of irregular sized, shaped, and distributed glands is a indication of chronicity, criteria for chronicity. Here, you see nicely neutrophil sitting in the epithelium. Can you all see neutrophil sitting in the epithelium? So this is cryptitis. It is stomach, even though I'm using the term, but I just want to know whether you are able to understand or not. This is a gastric biopsy where you have to look for H. pylori, because the H. pylori secretes some chemotactic factors for neutrophils. That's why the neutrophils come. Okay, and this is a crypt abscess. This is advanced active inflammation. Neutrophil sitting in the glandular space. So this is cryptitis and this is crypt abscess. Here also you can see cryptitis. And this is again H. pylori in high power. Previously I showed you the HNE, and this is a Giemsa stain. But please remember, the best stain is HNE. Even though I am able to show you a nice picture from Google here, all the Giemsa preparation won't show like H. pylori nicely like this, because there will be lot of background staining. So the best stain for H. pylori is careful examination of HNE. Here, HNE picture showing goblet cells in a gastric mucosa. These are the goblet cells are taking blue color in Alcian blue, whereas the gastric epithelium is taking the PAS color. Okay, so this is Alcian blue PAS, intestinal metaplasia of the gastric mucosa. Here, the history is this biopsy is taken from the body of the stomach. In the body of the stomach, you have to see a lot of fried eggs. These are all the parietal cells in addition to mucin secreting cells and chief cells. Okay, these are the parietal cells. When you don't see the parietal cells in the gastric fundic mucosa or gastric corpus mucosa, then you have to call it as pyloric metaplasia. This is very, very important because you see it in autoimmune gastritis. Sometimes the stomach can show acinar structures resembling pancreas. Then it is known as pancreatic acinar metaplasia. This can also happen in the small intestine. There, when you do staining for amylase or trypsin, it will be positive. But on HNE itself, you can see pancreatic acinar-like structures in the GIT. Then it will become pancreatic acinar metaplasia. Here is a best example of atrophy. Again, unfortunately, there is no defined number of glands to be same, because this is age dependent, patient size dependent, patient race dependent. So we don't have like 100 glands normally present, less than 100 is atrophy. Atrophy is it's a semi-quantitative, okay, less in number. Here you can see, and you can see prominence of the lamina propria. See here, glands are more in number, but here it is less in number. Okay, because of relatively less number of glands, this is atrophy, and thickness of the mucosa is also relatively less. Okay, and you see the lymphoid aggregates. So this is a chronic atrophic gastritis. Always rule out autoimmune disease and overlying H. pylori. Look for the history of pernicious anemia. I hope this you all can diagnose now. This is proliferative or non-proliferative. Remember those 4 questions. This is proliferative. with ATP or without ATP? With ATP. With invasion or without invasion? In this field, we cannot judge the invasion. So this is a proliferation with the ATP. And see the glands stratify, and loss of mucin or less of mucin, and there is loss of polarity. Okay, look at this nuclei running like in this direction. Look at this nuclei running in this direction. So clearly loss of polarity, and the nuclear stratification is reaching the top of the epithelium. Marked apoptosis. Okay, it's too thick to see the mitosis, but here you can see the mitosis. So this is stratification, loss of mucin, mitosis, apoptosis. So this is dysplasia. But this dysplasia is the epithelium is reaching the top, and there is loss of polarity, and I don't see, probably cribriforming may be coming here. I don't see in the center of the picture. So I will think of high grade dysplasia. So I was just drawing this to my trainees. In this one gland, I want to show all the spectrum. So this is normal colonic mucosa, single layer with uniformly distributed goblet cells. And you should know that idea also. The number of goblet cells are less on the right side, and the minute you are going towards left side, the number of goblet cell will be increasing, as the functionality of mucin secretion is more on the left side of the colon. So this is the single layer with preserved goblet cells. Whereas here the goblet cells have disappeared, and these blue nuclei started stratifying. Okay, and these pink stars are the mitosis, and these blue dots are the apoptotic bodies. Okay, so you can see the blue dots, you can see the mitosis. So you see stratification, loss of mucin, mitosis, and apoptosis. So this is dysplasia. Now question is high grade or low grade. Here the dysplastic epithelial cell, the stratified nuclei are reaching only up to middle 1/3. The top upper 1/3 is free of nuclei, and all the nuclei are running in one direction. The polarity is maintained. No micropapillae or no cribriforming. So it is low grade dysplasia. When you come to this quadrant, you see the stratified nuclei showing the micropapillary formation, and when these micropapillae fuse together, they form the cribriforming. And here you can see the nuclei, stratified nuclei are reaching the top of the apical membrane, and they are running in different direction. Look at this nuclei, it's running in this direction. Look at this nuclei, this is running in this direction. Look at this nuclei, it is running in this direction. So three direction of these three nuclei. So it is loss of polarity, and you see lot of apoptotic bodies and lot of mitosis. So this is a high grade dysplasia. Whereas in carcinoma, it is same like high grade dysplasia. It is breaching the basement membrane and going into the lamina propria, and this is the muscularis mucosa. So it is going through the muscularis mucosa into the submucosa. That's why it is diagnostic of invasive carcinoma. You see only this gland, then it will be under high grade dysplasia, and this is the terminology intramucosal carcinoma they are using in Europe and other countries. Whereas in US it will be high grade dysplasia, and invasion only once it crosses the muscularis mucosa and goes into the submucosa. I hope you understand all the criteria of dysplasia here. So we are done with surface epithelium, we are done with the glands. Now we are going to lamina propria. In the lamina propria, you have to look for edema, muscularization, inflammation, organisms, fibrosis, vascular changes, atypical or foreign cells that can be seen in inflammation, radiation, benign or malignant conditions. Let us see one by one. Here there is a lot of edema. The epithelium, the glands are pushed apart each other, and this may be procedure related. This may be seen in chemical gastritis, lamina propria edema. It's a very non-specific finding. not diagnostic of anything, but whenever you see, think of chemical gastritis. This is muscularization. You see in the high power muscle coming in the lamina propria. Lamina propria should be free of musculature. The muscle should be there only in the muscularis mucosa. Here in this low power, you can see the muscularis mucosa is hyperplastic and it is sending the muscle bundle into the lamina propria. This happens in chemical gastritis in case of stomach and in cases of mucosal prolapse in colon. Remember that solitary rectal ulcer syndrome, which is totally misnomer. It is neither solitary, can be seen in other parts other than rectum. There may not be any ulcer, there is no syndrome. So the whole solitary rectal ulcer syndrome is a misnomer. But muscularization of the lamina propria is one of the criteria for mucosal prolapse that is happening in solitary rectal ulcer syndrome. And this is a gastric mucosa. Here, when you see muscularization of the lamina propria, you have to think of chemical gastritis. Villiform surface changes, lamina propria edema, and muscularis mucosa coming into the lamina propria. These are the three criteria. When you see it in the antral biopsy, think of chemical gastritis that can be seen in biliary reflex or NSAID use. Lot of inflammatory cells. Remember, I told you, if you see more than 5 neutrophils, more than 5 eosinophils sitting in the lamina propria, or more than 15 eosinophils per high power field, that is a eosinophilic gastritis. If it is from the stomach, if it is esophagus, it is eosinophilic esophagitis, eosinophilic enteritis, eosinophilic colitis. So eosinophilic gastroenteropathy. Here it is a cryptitis and crypt abscess. And the glands are also pushed well apart. The glands are showing variation in size, shape, distribution. So this is chronic colitis with activity. These are granulomas in the lamina propria. Think of tuberculosis in India, sarcoidosis, fungal infections, or idiopathic, or foreign bodies. So those are all the 4 main things. Any granuloma, infectious or non-infectious. When infectious, is it necrotizing or non-necrotizing? Lymphoid follicles, again, abnormal in the stomach, and they are seen in the lamina propria, chronic gastritis. You can all identify these beautiful inclusions and some cytoplasmic inclusions also, nuclear and cytoplasmic inclusion. These are CMV infection. Okay, these are all involving blood vessels. One hint for CMV, it affects mesenchymally derived cells first, endothelial cells and the fibroblasts. Since it's involving the endothelial cells, it produces vasculitis and ischemia, and that's why most of the CMV enteritis or CMV gastroenteropathy is associated with ischemic changes because of the overlapping vasculitis. Here it is involving more epithelium, whereas here it's involving more endothelium. This is a special strain, gastric biopsy again. See a lot of macrophages with the pink stuff. This is a AFB strain. Whenever you see a lot of pink stuff in the lamina propria within the macrophages, think of Mycobacterium avium intracellular. Then now we have to assess the fibrosis in the lamina propria. Again, fibrosis is one of the chronicity criteria. This is normal glands, whereas here gastric mucosa with increased reticulin rich. Another thing you have to remember, reticulin strain, you have to say reticulin poor or reticulin rich. You should not say reticulin absent or present. Reticulin will be always present, but is it poor or is it rich? That is the interpretation. This is again another indication of chronicity. Another interesting condition which I saw in Dr. Gonzalez Twitter, you can see the dilated vascular spaces or blood vessels of varying sizes dilated in the lamina propria and in the submucosa. This colonic biopsy got it with a history of refractory inflammatory bowel disease, but he exactly diagnosed this condition, which is new to me until I saw this Twitter, and clinicians never agreed with that. They went for resection, and in the resection You see like a AV malformation, isn't it? Thick and thin blood vessels of varying sizes are seen. In high power, you can see very thick vessel wall with a narrowing of the lumen, whereas here it is relatively preserved. So you want to know whether it is a vein or artery. Please believe me, this is a vein and this is an artery, and that is proved by the elastic tissue stain. These are all pictures from Dr. Gonzalez's Twitter, and you can see here there is no internal elastic lamina, whereas here there is an internal elastic lamina. So this is a branch of mesenteric artery, whereas this is a branch of mesenteric vein, and there is a condition called as idiopathic myointimal hyperplasia of the mesenteric vein. I don't know how many of you have heard this company. There's a company called His Master's Voice, which we call HMV before. His Master's Voice. This dog is listening to the master's voice here. And another funny question, that is this dog male or female? Because it is his master's voice, it is male. I know it is not pathology, but talking of too much of pathology, sometimes it is toxic. So this is a fabulous condition, idiopathic myointimal hyperplasia of the mesenteric vein, where you see a lot of dilated blood vessels of varying sizes, probably venous tributes or venous branches in the lamina propria. So very characteristic of this IMHMV. And the exact cause is not known. They are predicting it is more like a fistula formation between the artery and vein, like a AV malformation, maybe due to trauma. It is commonly seen in young males, and they present with the signs and symptoms of inflammatory bowel disease. Interesting condition. Here the lamina propria is full of cells with a distinct cell border, abundant foamy cytoplasm, most of the time centrally placed nucleus. Sometimes it is pushed to the periphery. The central nuclear placement is very important for a diagnosis of xanthoma. Whereas Signet cells, it will be predominantly peripherally pushed nucleus. And when you have doubt, you do a CD68, which will be strongly positive. And so this is a gastric xanthoma. Here it is more like a Signet cells. And when you do cytokeratin, it will all be positive. Okay, so it's a poorly differentiated Signet cell carcinoma. And there are only 3 types of pathologies in the world. And this I got it again from Twitter, I think from Sanjay Hobatyaya. Pathologies who missed Signet cells, pathologies who are missing the Signet cells, pathologies who will be missing the Signet cell carcinoma. So it's a very, very, very difficult condition. We have to keep our eyes widely open to see these Signet cells, especially in biopsies. Here was what is happening. Very poorly differentiated cells. Okay. High grade malignancy. Again, definitely it is proliferative disease with the atypia. Again, invasion metastasis we cannot see from this picture. But whenever you see this much of poorly differentiated cells in the gastric biopsy or in the colonic biopsy, and predominantly the atypical cells are situated in the lamina propria, think of lymphoma. This is a CD20 IHC, strongly positive. So this is a non-Hodgkin's lymphoma, possibly diffuse large B cell type. So we are done with surface epithelium, we are done with the glands, we are done with the lamina propria. Now we are moving to muscularis mucosa. The only 2 things in muscularis mucosa: hyperplasia, where it extends into the lamina propria. We already talked about it. It is seen in biliary reflux or NSAIDs, or you have to look for atypical or foreign cells in the muscularis mucosa. This is the muscularis mucosa hyperplasia, where again you can see the muscle fibers running into the lamina propria. If you are in doubt, you can use the trichrome stain, where you can identify the muscle running up there. And you can see nice intestinal metaplasia there. Again, the number of glands are less in here. So this is chronic atrophic gastritis with intestinal metaplasia with muscularization of the lamina propria. More than one pathology involved in this biopsy. These plastic changes seen above are known as TIS. Once they cross the muscularis mucosa, then only they are eligible for T1. So muscularis mucosa acts like a barrier. Here in this picture, you can see the muscularis mucosa acts like a barrier. So this is only high-grade dysplasia. Whereas here you can see the malignant glands going into the muscle bundle, and malignant glands are seen on both sides of the muscle. So this is at least T1 carcinoma or invasive carcinoma extending beyond the muscularis mucosa. Now we are going to submucosa, where you have to see the vascular changes, neural hypertrophy, atypical or foreign cells. See, this is a Dysplasia lesion where you can see a massively dilated vascular space which has ruptured into the lumen, causing severe hemorrhage. If I understand, if I know correctly, this is from autopsy case. Here there is another autopsy case, extensive ulceration and ischemic change with a hemorrhage. And when you take sections, the blood vessel showed nice cholesterol emboli. Again, clinical history is very important. Any dislodgement of the atheromatous lesions, so for example, carotid endarterectomy or abdominal aortic aneurysm repair, that history is very important for cholesterol emboli. Here there is more like a neural hypertrophy. Whenever you see neural hypertrophy, you have to think of Crohn's disease. Here you see the ganglion cells in the submucosa. When you see ganglion cells, these are normal component of the submucosa, and why I am showing it, sometimes you may think of malignancy, here you may not think of it. And another point, these are all the cells we are looking in congenital megacolon. So if you don't see them in the submucosa in frozen section, again this will qualify for congenital megacolon. Here another tricky thing, this is submucosa and you can see the poorly differentiated cancer cells. Okay, and these are invasive carcinoma. Now you know, see this number of blood vessels there. That's why we need the cancer cell to come into the submucosa to call it as cancer cell, because the incidence of metastasis is very high once they come into the submucosa. So this brings the basic concepts learning to an end. I want to summarize. In the resection specimen, there are 4 layers: mucosa, submucosa, muscularis propria, and serosa or adventitia. In the mucosa, you have to see it in the lumen, changes happening in the lumen, changes in the surface epithelium, subepithelial glands, in the lamina propria, and in the muscularis mucosa. And always remember to ask 4 questions. Is there any proliferation? Is there any atypia? Is there any invasion? Or is there any metastasis? Depending upon that, the lesions can be classified into non-proliferative lesions, proliferative lesions without atypia, proliferative lesions with the atypia, atypical proliferative lesion without invasion, atypical proliferative lesion with invasion, invasive atypical proliferative lesion without metastasis, invasive proliferative atypical lesion with metastasis, either in the lymph node or in the systemic metastasis. If you put any disease into one of this branch, the treatment will be the same. That's why we have to follow this pattern analysis. All non-proliferative lesion, treatment is the same. All proliferative atypical lesion without invasion, treatment is the same. That's why this pattern analysis is very, very important. Thank you for patient listening. Probably in the next part, we will see how to approach lesions for each specific organ. But understanding the concepts discussed in the video is very, very important to analyze the further parts of the approach to GIT lesion. As usual, any comments, any suggestions, anything to make our life more easy are always welcome. Have a great day. Bye.